This next case is of an endovascular treatment of a ruptured posterior communicating artery aneurysm with difficult and abnormal aortic arch anatomy. It is important when considering coiling of an aneurysm to also consider the access, and the access often starts from the femoral artery all the way to the aneurysm. This is a 79-year-old female who came to the emergency room with the worst headache of her life. She was found to have a ruptured aneurysm with a Fisher grade 4 and a Hunt-Hess 4. CT scan showed hydrocephalus with severe subarachnoid hemorrhage. Her CT angiogram showed a left posterior communicating artery aneurysm, which was believed to be ruptured. As you can see from the CT scan, there is diffuse subarachnoid hemorrhage, and the CT angiogram shows an oblong, irregular posterior communicating artery aneurysm. The CT angiogram also demonstrates a very complex aortic arch. Safe navigation of the aortic arch is critical for an endovascular surgeon who wants to treat intracranial pathology. Understanding how to navigate type 3 arches or aortic arch complexities is vital for success for treating intracranial pathology. Here you can see a Simmons 2 soft catheter being trapped in a type 3 aortic arch with a bias to the left. When such arches exist, it is often difficult to find the orifice of the common carotid artery. Finding the origin of the common carotid artery in type 3 arches or curved arches such as this one can be quite tricky. We found that the use of a VTEC catheter inside a 6-French guide catheter and married with an 038 glide wire tends to bring the most success. Navigation through the aorta often starts with an aortogram that will give you an idea where the great vessels originate. Once we can determine where the origin is, we will engage this VTEC catheter into the origin and then use an 038 glide wire to navigate the VTEC catheter slightly distal and then climb both the VTEC and the 038 wire with the guiding catheter as is demonstrated here. Once we are outside the arch, we are able to get very distal access with our guide catheter. We do not need to be too aggressive with the distal access as we are not delivering stent technology, but rather we are only delivering coils. Here you can see from the angiogram the likely rupture site given the distal lobule of the posterior communicating artery aneurysm. We bring the microwire and microcatheter into the intracranial circulation, and once we are in the proximity of the aneurysm, we begin to think about catheterization techniques. Under high magnification roadmap, we advance the wire into the aneurysm, being sure to keep the wire away from the believed rupture site. As we pull the wire back, we try to advance the microcatheter over the wire, constantly using visualization to prevent the microcatheter from going through the aneurysm rupture site. Once the catheter is in the aneurysm, somewhere 2/3 distal to the neck and 1/3 proximal to the dome, we begin to deliver coils. We use multiple projections in the AP and lateral plane, which best separate the neck from the parent vessel. Again, we use coiling technique, coiling from the neck of the aneurysm, pushing the coil mass distal while developing good packing density at the neck. We progressively size the coils from large to small until such time that we feel we have protected the aneurysm and there are enough coils that would lead to complete thrombosis of the aneurysm. This angiogram shows that there is still significant patency of the aneurysm and more coils will be needed.